Hip dislocation. 1. Anatomy. The hip joint is a synovial, ball and socket joint. Stabilizing factors. Bony. Spherical femoral head well fitted in the deep acetabulum, with 70% coverage. Labrum. Deepens the acetabulum and contributes to stability. Static. Capsule. Very strong. Ligaments. Iliofemoral, pub of emeral, and ischiofemoral ligaments. Dynamic. Joint surrounded by strong muscles for additional support. Sciatic nerve. Leaves the pelvis at the greater sciatic notch below the piriformis. 2. Types of hip dislocation. Anterior dislocation. Occurs less frequently, 10 to 15%. Mechanism. Trauma to a flexed, adducted hip, e.g., trauma to a flexed knee. Posterior dislocation. Most common, 85 to 90%. Mechanism. Often due to a dashboard injury, flexed knee, flexed adducted hip. Superior, pubic, dislocation. Occurs when the hip is extended. Inferior, obturator, dislocation. Occurs with a flexed hip. 3. Clinical presentation. Posterior dislocation. Flexion, adduction, internal rotation, shortening. Anterior dislocation. Flexion, abduction, external rotation. 4. Imaging. X-ray, AP, cross-table lateral, and oblique views. CT. Used post-reduction to check for associated fractures. MRI. Follow-up to detect avascular necrosis, AVN. 5. Classification. Thompson and Epstein classification. Simple dislocation. No associated fractures. Complex dislocation. Associated femoral head or acetabular fractures. Epstein classification. Superior dislocation. Inferior dislocation. Posterior wall fractures. Comminuted posterior wall fractures. Femoral head impaction. 6. Treatment. Initial management. Closed reduction under anesthesia, sedation. Alice method. Traction in line with deformity, flexion of the hip and knee to 90 degrees while maintaining traction, and gentle rotational movement. Stimson gravity method. Patient prone with leg hanging off the stretcher, vertical traction, and gentle rotation. Bigelow-Kevers method. Traction in line with deformity, abduction and external rotation to lever the femoral head into the acetabulum. Post-reduction. Test for stability and perform a neurovascular, NV, assessment. CT. To confirm reduction and check for associated fractures or incarcerated fragments. Traction. Concentric, stable. Bed rest with protected weight bearing, WB, for 4 to 6 weeks. Concentric, unstable. Traction for 4 to 6 weeks. Non-concentric reduction. Open reduction required. Contraindication for closed reduction. Ipsilateral femoral neck fracture. 7. Operative treatment. Indications. Irreducibility, non-concentric reduction, e.g., incarcerated fragments, associated femoral neck fractures. Approaches. Posterior dislocation, Coker-Langenbeck lateral, Hardinge, approach. Anterior dislocation, Smith-Peterson or anterolateral, Watson-Jones, approach. For associated fractures, open reduction and internal fixation, RIF, for fractures of the femoral head or acetabulum. Arthroscopy, to remove intra-articular fragments or evaluate labral, cartilage injury. 8. Central dislocation. Mechanism. Occurs when the femoral head is forced through the acetabular floor, often caused by a fall on the side or direct blow to the greater trochanter, GT. And 9. Complications. AVN. Avascular necrosis due to delayed reduction, greater than 12 hours. Sciatic nerve injury. Affects 10 to 20% of cases. Myositis ossificans. Recurrence. Rare. Irreducibility. Due to incarcerated fragments, buttonholing of the femoral head through the posterior capsule, interposition of external rotators, or torn labrum.